So don't think just because you're in pressure control. Okay, my memory's full. I got you. Don't think just because you're in pressure control you don't need a volume range, because you still do. Because you're still going to have a target range that you want to use for your patient. Then your respiratory rate, 10 to 14. FiO2 is going to be 40 to 60%, unless they're like a trauma, code, CHF, like a patient in your ER. Then they're going to get 100%. How much PEEP do we start? 5.
Can we write like greater or equal to 5?
Huh?
No, you start at.
No, you start at 5.
Oh, okay.
Yeah, we don't go less.
Got it.
Everybody gets 5. Like say your patient was on, so we could say 5 unless they were on like a higher setting already. Like say they were on BiPAP of 14 over 10. Then it wouldn't make sense to start them at 5. So what else do we need to set? So these would be like our orders, but what else have we talked about that we need to set?
Alarms.
Okay, we'll get to alarms in a minute. What else? IE ratio, I time. So I time, and remember this is all just going to depend on what you can set. I time 0.8 to 1.2, IE ratio 1.3 or higher. What's another thing we've talked about setting that's important? It relates to the I time.
Flow.
Flow. Yep, 40 to 80. 60 is a really good spot. Just remember, if you have to compromise one for the other, which one takes precedence? I time always. So if your flow is lower than this range, but your I time is where you want it to be, then it doesn't matter. I time takes priority. And then yesterday you guys talked about that flow pattern,
Square and decelerating.
square and decelerating. Which one did she say was better?
Decelerating.
Decelerating. So decelerating, if you can set it. Do you know which mode that the decelerating defaults in? Pressure control. So in pressure control, you can only have decelerating. You can't change it. So it's going to be automatically default to decelerating and pressure control. And then in volume control, you want decelerating if you can change it. It doesn't always let you change it.
So if you can't change it, it's going to be a square.
Correct.
Even volume control.
Yes. Do you know, can you change the flow in pressure control?
I don't know.
No, you can't, or no, you don't know? No, you can't. So you also cannot change the flow. So these would only be volume control only. You cannot change the flow in pressure control. Because your volume varies with your pressure and your compliance and resistance, so your flow has to vary, because those two kind of go hand in hand. So if I gave you a pressure control setting and I told you to set a flow, would you do that?
No.
No, because you can't do that in pressure control. And then if I'm in SIMV, what's one other setting I can add? Pressure support. I started to say it.
Mhm.
So that could be something else you could set, but only in SIMV. And usually we start at around 5. And Ella,
Yeah.
can you tell me what pressure support does?
Supports pressure.
Fabulous. Jazz.
I'm not 100%, but pressure support is like the baseline of pressure, correct? And then pressure control is the limit?
No.
Isn't it like will help, it's like an extra push to like get overcome like a tube or something?
Yeah, that's pretty much. So
Yeah.
what kind of breath is this?
Mandatory.
Mandatory. It's all positive, right? And it's big breaths. What kind of breath is this?
Spontaneous.
Spontaneous. So this would be AC or SIMV?
SIMV.
Okay, SIMV. This is the spontaneous, and then pressure support can be used to augment your spontaneous breaths. So that would be PSV. So if your tidal volume is too low on the spontaneous breaths in SIMV, then pressure support will help bring the volume up. Think of it just like BiPAP. BiPAP, we have our IPAP and EPAP and have pressure support to help increase tidal volume. Pressure support on SIMV basically is doing the same thing. It's adding pressure to the patient's spontaneous breath to help bring their tidal volume up. So it's only used on the spontaneous breaths, it's never used on the mandatory breaths. And ultimately, we want it to get our patient's tidal volume to 5 to 8 mLs, the same one, same range for their spontaneous breath. So if you put someone in SIMV and their spontaneous breath is 100, then they need pressure support to help bring that up, or they're not gonna be able to have appropriate ventilation. Does that make sense? Yes, no, maybe? No, it doesn't make sense.
Can you just repeat that one more time? I
Okay.
think we just need to hear it a couple times.
So when our patient is spontaneously breathing, they're getting their own tidal volume. They're on a vent, and it's not good enough. Let's say we put them on the ventilator and their spontaneous breath, not the machine breath, the spontaneous breath is only 100 mLs. Their spontaneous tidal volume should be 5 to 8 mLs per kilogram. So probably 350, 400, just ballpark, 350, 450. So if it's only 100, it's nowhere near where it should be. So if we add pressure support to the spontaneous breath, it's gonna add pressure, just like BiPAP does, to help bring up the tidal volume on the spontaneous breath. Yes?
So the pressure has to be adjusted for their spontaneous breaths to meet that range.
Yes. So you would start at 5, and then you can go up or down on it. Just like I would go up or down on IPAP, I would go up or down on my pressure support to get that range that I want. Because if your patient has his mandatory rate and this spontaneous rate only has tidal volumes of 100, what do you think is going to happen if you keep him here at 100 on his own?
He's gonna have a
Yeah, but what else is going to happen? Why he's going to have an increased work of breathing because his volume on his own is only 100, so it's not going to be enough. And so the pressure support is going to help augment that. Does that make more sense now? Share it again. You
The
got
way
it?
to remember it is like a short person that needs a pair of heels to reach the top shelf.
Yeah, I like it. Short person needs heels. That would be me, but I'm not wearing heels. I'm getting a step stool.
Or a step stool, yeah.
Okay. What kind of breath is this?
Mandatory.
This one?
Mandatory.
This one?
Mandatory. Spontaneous. Assisted.
Actually, it's still a mandatory, but it's a patient-initiated
Okay.
mandatory, because you're still getting this mandatory breath, just my patient initiated it.
Okay, who's checking?
Oh, because of the drop.
Yeah, so it's a patient-initiated mandatory breath. So it's still mandatory because the ventilator's controlling the entire breath. The patient just started it. Got it? And is this AC or SIMV? AC. Yep. So AC, all full machine breaths, SIMV, part machine, part patient, you can add pressure support. Can you add pressure support over here?
No.
No, why not?
It's not SM.
Okay. What about it, it keeps you from adding pressure support? There's no spontaneous breathing because it's all mandatory. So no pressure support here. No spontaneous.
And what mode is that? That's AC.
AC whatever. How many ACs can we have? AC what? VC, AC, PC, PRVC. Yep. And you can have the same with SIMV.
So if it's an ACPC, then
Still no pressure support. AC anything, no pressure support. SIMV anything, you can have pressure support. So now to the question, pressure control is
So we're doing
the pressure
and volume?
control is here. What's my set pressure on my pressure control breath? Pressure support is the spontaneous breath. So control is the mandatory breath. So your pressure control setting is the pressure setting on the mandatory breath. The pressure support setting is the pressure setting on the pressure supported SIMV breath. So you can have pressure control and pressure support together. Because pressure control would be the pressure for the mandatory breath. Pressure support would be the pressure for the spontaneous breath.
so pressure control is for mandatory breath.
Yes.
So is pressure control and AC,
Or SIMV, either one.
either one?
Mm-hmm.
So when you have both, it's SIMV and PC?
Yes.
Okay.
She said when you have both, it's SIMV PC.
We have
Because you would
pressure
have
control
pressure
and
control with pressure support. Right. So remember, SIMV, pressure support. AC, no pressure support. So if you see an order for ACVC and it has pressure support in there, that's no go because you can't do it. Because you have no spontaneous breaths. Don't confuse it with, some people say, I can't do pressure support because I'm not in pressure control. That has no bearing on it. You can't do pressure support in any AC mode because you don't have any spontaneous breathing.
They're just patient triggered.
Yeah. These are actual spontaneous that the pressure support can go on. Yes,
Back like a minute or two.
it's okay.
You said pressure control is on mandatory breaths for AC or
Or SIMV, it doesn't matter.
thank you.
So pressure control can be in anything, but pressure support is only in SIMV.
Correct. So, because remember, once we get down to whether I'm gonna be all mandatory or mandatory and spontaneous, what does volume control tell me about it? What, Haley?
You get a set volume?
Yeah. The mandatory breath is gonna be a set volume. If I'm in pressure control, AC, what kind of breath is the mandatory breath? ACPC. It's a pressure breath. So instead of getting a set volume, you're getting a set pressure. And if you're in PRVC,
Pressure regulated volume control.
Pressure regulated.
Set pressure regulated.
So you have both
Yeah, kind of.
huh?
pressure regulated volumes.
Control.
So pressure, PRVC, you set the max pressure and it will adjust to get the volume that you want. Pressure regulated volume control.
First time I hear that, just letting you know.
Oh.
Say that
I
again.
did not
You
know
said the-
anything about
Here.
this before.
So let's do this.
So Ms. Foss, can you say that again? You said you set the max pressure.
Yeah, I'm gonna say it again right now. So in PRVC, you set the max pressure and a target tidal volume. Is PRVC an open loop or a closed loop?
Close.
Closed loop, because it's gonna auto adjust based on what it's watching. So max pressure, let's say we go to 30, and our target tidal volume is 450. What's nice about PRVC and why a lot of places use it is because the ventilator is gonna use the lowest possible pressure to deliver this target tidal volume that you want. So when it first starts out, it's gonna do a breath hold, and it's gonna determine what the patient's plateau is. I mean, this is just informational. It's gonna do a plat here. And let's say your plat is 15. So then that's gonna be the starting pressure it uses in PRVC. Yes?
So this is what she was talking about yesterday when she said it's gonna do test breath and
Yes.
then adjust based on that.
Yes.
Okay.
So test breath, do the plateau, the pressure's 15, then that's gonna be the starting pressure the ventilator's gonna use in PRVC to try to get 450. So it's always monitoring to get 450. So let's say it gets 450. And it's never gonna be exact, I'm just doing this to demonstrate. So it's gonna stay at 15 and it's gonna go, oh good, I'm using 15 of pressure, I'm getting 450, I'm happy. Because you're getting the target tidal volume that you want. But what the advantage to PRVC is if your tidal volume begins to change, then the pressure can change as well. Haley?
So you set a max pressure and it only gives the like minimum amount of pressure you
Needed,
target?
yes.
Okay.
And it will not go above that 30.
No.
Okay.
And this is set in the alarms. So this max pressure you have to set in the alarms. So when you're going to set PRVC and you're given a max pressure, you're gonna go to the alarm limits and set that max pressure. Okay? So I'm doing 450, I'm good. But now let's say all of a sudden I'm doing my 15. Now I'm only getting 300. Yep, it's gonna go up. Every event's a little different, but it usually does it in increments of 3 to 5. Again, you're not gonna be tested on that, but it's not gonna go right to 30. So it's gonna go up, let's say 18. So this would be 3 more 15s, because it's, oh yeah. Now it goes, oh, I'm not meeting my target anymore. So I need to increase my pressure to try to meet it, and then it goes up to 18 or wherever to try to get 450 again. Haley?
So what kind of patients would you see on PRVC?
PRVC is good for your normal everyday patient that doesn't have a lot of compliance and resistance problems. So if you get a lot of compliance and resistance problems, we're going to talk about being in pressure control and some other things. Kaylee?
So it changes based off of 3 breaths that are under?
Yes. Yeah, it has to be 3 breaths. That's the one thing I was just going to get to. Has to be 3 breaths in a row consecutively because it's not going to make a change based on only 1 or 2. So the marker is 3. So if it went to here, it wouldn't make a change. It goes to here, it doesn't make a change because that's now only 2 out of 3. Now 3 out of 3 have a problem. Now it's going to make its change. Mitch?
I was just gonna ask the same thing.
Oh, okay.
But if you have a good breath say between those 3, it's not gonna make a change.
No, has to be 3 consecutive. Because the patient could have hiccuped, they could have coughed, they could have moved, it could have been a many different things. So it's not going to do anything until it gets to that 3. And then the opposite can happen. Let's say we're going to now 600 all of a sudden. Then it's going to go down on the pressure to get it back down to where you want it. So it's just continuously monitoring. And if it gets to the max pressure, it will alarm and it will tell you that the pressure limit is reached. But it won't, it'll keep ventilating. Unlike where you hit the high pressure alarm, what does it do? It stops. Remember how we talked about that? High pressure alarm, if his breath stops. Yes?
Yeah.
In PRVC, you hit the high pressure, it's gonna keep going because it's gonna say, hey, I'm still ventilating your patient, but by the way, you need to come do something because I can't get the volume that you want anymore. So that's one of the differences to PRVC. It's used a lot all out there. If you haven't seen it already, you will next term. Sutter uses it all the time. It's a good mode. So then again, you have PRVC in either one. So, and just like pressure control, no pressure settings modes can I do flow or flow pattern. They're going to default to those. Kaylee?
In, PRVC, you can never get a spontaneous breath?
You can.
Okay.
Yeah, it would still do the same thing, either spontaneous or mandatory. If it's a mandatory, it's gonna use whatever the last pressure was. If it's spontaneous, it'll be spontaneous. I will tell you though, you will mostly see PRVC and AC. Just AC, PRVC, just let the patient keep ticking along doing what they're doing.
Is our max pressure always gonna be 30, 30,
No.
35?
30, 35,
Okay.
yeah. You never wanna go above that. Questions? Okay, so, the alarm settings. The thing with alarms is we're gonna set them in the classroom at certain parameters, and they're literally just the numbers on your slick that you have. You look at the median, like the average range of what your patient's doing, and then you go above and below that. So if you look on your slick, it'll tell you like tidal volume alarm is 100 above, 100 below. Yeah, if it's 3 digits, it's 100 above and below. If it's 2 digits, it's 10 above and below. And if it's 1 digit, it's 2 above and below. That's how. So minute ventilation of 6, you go 2 above and below. So it's a real easy way to remember, you guys. If your number is 3 digits, you go above 100 above and below. If your number is 2 digits, you go 10 above and below. And if your number is 1 digit, you go 2 above and below. So minute ventilation of 5, you would go to 7 and 3. Pressure of 10, you would go 20 and, well, not quite 0. I know they're on one of them, I just don't remember which one. So we'll look. Anyways,
Can you say that really quickly and what's
I can say it slowly one more time. Okay, so if the number that you're setting an alarm for is 3 digits, like tidal volume, it's 100 above and below. 100 above the average, 100 below the average.
Has to still stay 3 digits basically.
Yeah, it will.
So has to not be below 100.
Well, unless you're dealing with a baby and it's different rules anyways. So let's say your tidal volume range is going between 400 and 500. Then you would go 600 and 300. 100 above the range, 100 below the range. Does that make sense? Yeah. If your number is 2 digits, so like peak pressure is 20. So you would go 10 above and 10 below 20 for your range. And then PEEP and minute ventilation and those numbers that are only one solid number, it's 2 above and below. So those are just ranges for here and guidelines. What you have to remember about alarms in the real world is every patient's different. So the whole idea behind alarms is to set them safely. If it's your high pressure alarm, you should not routinely be going above 35. That increases your risk of barotrauma immensely. So if you see an RT who's putting their high pressure limit at 55, is a problem. They sometimes are getting set just so they won't go off. That's crazy. Yes?
For our calibration, does that include testing the alarms, like on the G5?
On the G5, you follow whatever the card says.
Okay, but other ones we don't have to test the alarm?
No, it's built in. And then the other thing, some of the ventilators have built-in alarm settings, so you won't even have a setting for it. Like the Servo has no low volume, has no low pressure, because it's automatically defaults to the setting, so you're not gonna set it. So if you don't set it, you don't write it. So if it's not on your vent, when you're doing your vent check, you would just put NA. Devin?
If we get the G5, we'll get the sheet. On
Yeah.
this one, right?
Yep. Yeah, you don't have to memorize that, but you do have to follow the sheet. Yeah, you'll be able to have the sheet. Yes, Sam.
So for high pressure, you don't want to go over 35 because it will increase their.
Correct.
Okay.
Other questions? Make more sense now? Yes, no, maybe? You guys are normally asking me 4 billion questions.
I feel like about the midterm.
Actually,
Questions usually
I,
happen after the lecture usually.
Huh?
I feel like the questions always come to us.
Yeah, and we'll be in lab, I'll be coming around. Did you guys get pictures or whatever you needed of this? Yes, Sam?
So basically on flow, if it's volume, I want to, if it has the option to put it for decelerating flow, and if it doesn't, just stick with the square.
Yep.
Okay. And in pressure control, it is decelerating, right?
Correct.
Awesome. Thank you.
Okay, let's review this ABG madness to make sure we're all on the same page, and then I'll let you get to lab. Okay?
Green.
A green.
Marker right here.
No, it doesn't work.
No? Oh.
As far as the choice portion,
Yes.
that's just gonna be all the like notes we took in class.
Uh-huh. Everything we've gone over.
It's multiple choice?
Huh? Yes, multiple choice. Yes, and I will also post some, oh, I gotta go through the book, it's a new edition. Oh, thank you. There's some review and case study stuff I have for, review as well for you guys to work on, but it's a new edition, I'm gonna have to look it up again.
Do you want us to keep recording the ABG review?
Yeah. Okay, ventilation. So, to make sure we understand, when I say it's a ventilation problem, I mean the patient has a high CO2. So, ventilation problem. High CO2. It doesn't mean a low CO2. If my patient has a low CO2, they're ventilating. They're actually overventilating. So are they overventilating because we're overventilating them, or are they overventilating because there's an oxygen problem? We'll talk about that in a minute. So a ventilation problem, I mean a patient with a high CO2 and a low pH, because I don't care if it's chronic. If it's chronic, I'm gonna leave it alone. So we're not ventilating properly, right? pH is low, CO2 is high. This will be accompanied by a low oxygen. Unless we just have them so over-oxygenated, but then that's our problem. But generally, if you're not ventilating, you're not oxygenating. So if ventilation is the problem, it's the primary problem, and it's what you have to fix. So if you see this, you need to fix ventilation. And we can do that by increasing tidal volume or increasing the respiratory rate. Don't make it harder than it is, you guys. It's 2 factors, volume or rate. Oxygen is not gonna fix ventilation. So if you're telling me there's a ventilation problem, I don't wanna hear change FiO2 or PEEP. It will do nothing. This is so important, which is why we go over it and over it and over it. And you got all kinds of practice ABGs, and I've got a whole folder full of more. Because if you can't look at an ABG and figure out what's wrong with it and make the appropriate changes on your vents, number 1, you won't pass your boards. Number 2, you won't be able to take care of a patient on a vent, and I'm just being honest. So for those of you guys who are struggling, we'll do more tutoring, we'll do more review, we'll do whatever you need, but you must get this down. So fix ventilation, tidal volume, or rate. If your tidal volume can be changed and it can be still within your range of reason, if it's almost at the top, you're not going to change it by 10. So it's tidal volume first. Then respiratory rate. So increase tidal volume first, then rate. Unless VT is maxed out. So if your tidal volume's maxed out, go to your rate. If your tidal volume's not maxed out, change your tidal volume. One of these only, not both. We fix one thing at a time, except for one exception, which I will clarify before we're done, just to make sure. Are there any questions on this? Okay.
You said the rate, we don't wanna go more than 14, okay?
No, that was a starting rate. If your patient's at 14 and their tidal volume's maxed and your CO2 is high, you'll go up. That's how you end up with patients with rates of 20, 25, 30. Because there are times when it's needed. So 10 to 14 was starting, because you're not gonna start that high, okay?
For tidal volume, if it's like 50 before the max, would you change it, or like when do you stop changing it?
I would say if you're up within 25 of the max, I wouldn't change it. Just to give you a ballpark, you guys, but some of this stuff is not black and white. Okay, oxygenation problem.
Wait, what if they're hyperventilating, then you would just decrease the respiratory rate?
Oh yeah, so, hold on. So ventilation problem, then if your patient is hyperventilating, because this is not a ventilation problem anymore, they're hyperventilating. If their PaO2 is less than 80, no, less than 60, sorry. Less than 60, it's an oxygen problem. And then you're gonna follow what we write here. So if your patient's hyperventilating and your PaO2 is less than 60, it's an oxygen problem. The reason they're hyperventilating is because they're hypoxemic. Okay?
Yeah.
So then you're gonna go here. If your oxygen, so 2, PaO2 is greater than 60, then you're gonna go down on your rate, then down on your tidal volume. So this one's opposite. Hyperventilation is almost always go down on the rate, unless it's because they're having an oxygenation problem.
Ms. Moss,
Yes?
if it's an oxygenation problem, in that case, we would only touch the oxygen.
Correct.
We would not do anything with the rate?
Correct.
Okay,
Because if you fix the oxygenation problem, you should
Oh,
fix the
good.
hyperventilation.
got it.
Yep. So if it's an oxygen problem, you're going to the oxygen criteria. If it's not an oxygen problem, then you're overventilating them, and you're gonna go down on your rate. Okay. So if you have an oxygenation, if your PaO2 is less than 50, what are you gonna go to? 100%. If your PaO2 is 50 to 59, what are you gonna do? Go up to 60% FiO2, and then increase your PEEP. Once you get to 60, you stop and you start on PEEP. Go to 60% FiO2, stop, and then increase PEEP.
Repeat, usually, or the increments that we go up.
2 to 3, I mean, 3 to 5, really. It depends, but 3 to 5. If you're going up on your PEEP and your blood pressure drops, go back down to the previous PEEP and start increasing FiO2. Everybody good with this so far? Okay, yeah. Tim.
When you say stop, you mean like increase that by 60?
Stop and then keep go, then go up on your PEEP.
Okay,
So if they're on 40, you would go 50%, 60%, stop at the increasing FiO2 and then go up on PEEP instead. Okay?
Stop and like watch what happens first, right? To see if the,
Well, yeah.
okay.
I'm just saying if you get to 60% and you're still having problems with your PaO2, then you gotta go up on PEEP.
Can you take ABGs in between all these changes?
Not necessarily, you might just check their stats. What would my stats, when my PO2 gets to 60, what is my SAT gonna be? 90. So we could say, just to be clear, SPO2, 80 to 90%. Or 80 to 89, I guess I better say. If my patient has a PO2 in the 40s, their SAT's gonna be in the 70s. Did you guys learn how to correlate those two? There's a very simple rule. 90, 80, 70, 60, 50, 40. 90, 80, 70, 60, 50, 40. SPO2, PaO2. That's why we say if somebody's SATs are in the 70s, they need to go on 100% non-rebreather because it means their PO2 is only in the 40s. So you guys need, it's a very, very easy to correlate. So if I have a SAT of 80%, my PO2 is around 50. If my SAT's 90%, it's around 60, which is why our marker for oxygenation is 90% and 60 PaO2 because the two go together. PaO2, 60 to 79. I maintain. Make no O2 changes. This is one of the hardest things for students. They see a PO2 of 64 and they want it to be 80. They told me the normal was 80 to 100. I want it to be 80, damn it. Not in the hospital. I know, I've had this fight over and over and over again. And the clinical setting, a PO2 of 60, we are happy. SAT of 90, we are happy. That's the marker to not prevent brain injury.
No.
And patients are sick, they're not going to get those nice happy PO2s you want. They're on a ventilator. Yes.
So that's the marker to not cause brain injury.
Correct.
You said not prevent. I was like, oh yeah.
Okay, to not cause brain injury. Okay, PaO2 greater than 80. Then you'll come down on your FiO2 to 60, and then bring down the PEEP. It's the opposite. Decrease FiO2 to 60%, and then bring down your PEEP to back to 5. And then once your PEEP's at 5, you could keep bringing down your FiO2.
So that's where we stop bringing down the PEEP, basically?
Yeah, 5
That's
is
good.
always going to be your baseline. These are the magic rules. For every test you take here and on your boards, this is how you do it. When I tell people to follow this and make changes, and they don't, you get it wrong. This is what everybody wants. And with the exception of this right here, this is how it's done clinically too. PO2's in the 60s. We're bringing down our FiO2. The risk of O2 toxicity is very great, even if you spend less than 20 hours on an FiO2 greater than 60. So we will never, ever, ever, ever withhold oxygen, but O2 toxicity mimics ARDS. And ARDS causes lots of inflammation and fluid and fibrotic damage. And when patients have O2 toxicity, the same thing happens. So those patients that need those FiO2s that high are typically ARDS patients. So they already have that damage going on, and now you're making it worse. So we're never gonna withhold oxygen because then we'll cause brain injury, but we need to follow the rules to bring it down as quickly and as safely to 60% as we can. Hold on, Mitch. Tim.
I just wanted to clarify for the last one. You said to bring down the peak to 5. What if the peak was like 15?
You're gonna
What
just
to do like
5 at a time. Yeah, or even 3. See how your patient's doing. If you're, the way you have to make these changes is how far away from 60 are you? Is your PO2 on 200? Well, then you can make a big change. Is it 90? Then you're gonna make a little change. Does that make sense? Mitch?
So with the hyperventilating, what if they're already at a respiratory rate of like 10? How low are you willing to go before you
If
switch
their
straight
rates-
over to volume?
If their rate's at 10 and they're still hyperventilating, then you have another problem. And you have to figure out what's making them hyperventilate, because it's not you.
So if they're hyperventilating, you always go rate first.
Mhm.
And
We don't go below 8 unless we're gonna try to wean somebody, so.
so unless
If your patient is like an AC and has a hyperventilating problem like that, I might switch them to SIMV to see if I can get them to, they might be just getting too many mandatory breaths. But there's probably another thing going on, either a neurologic problem or a fever, or they have some kind of high metabolic demand for some reason, which means then you're not meeting another need, or the patient wouldn't have the need to hyperventilate. Who else? I saw somebody, I just said I would get to them, and then, who else had their hand up over here? No? Okay. Devin?
We talked about kind of like bringing the peak down and monitoring. How long are you monitoring for? How long is that?
Oxygenation doesn't make changes automatically. I would wait 10, 15 minutes and then see if you're stabilized, and then if not, then you can keep making your changes. CO2 is gonna be quick. So depending on if you have an end-tidal CO2 in place, which most vet patients do now, you can trend it, kind of see where it started, and then is it going up or down based on your changes. And then maybe when you think you're where you want to be, then you can draw an ABG. Because if they don't have an art line in, I'm going to keep sticking them a billion times.
How long will that take to kind of see that change in the CO2?
Well, CO2 is going to be quick. CO2 you're going to see probably within a few minutes. But we typically make changes and wait at least 20 before we do an ABG. Unless you can really see that what you're doing isn't working, then go ahead and make more changes and then wait to do your ABG until you feel a little bit better with it.
So at 20 minutes, you make a change. Are you required to stay in the room?
No. No. But if your patient SATs in the 70s, are you going to leave? No. So is your patient SATs 88 and they've been there all day and you're trying to get them above 90? Are you going to leave? Yeah, because you're going to make a change and come back. So it's going to depend on the stability of your patient. If your patient's very unstable, you'll need to stay with them. If you're just trying to get things regulated, then you're going to go do other things and come back. That's when it comes clinical judgment at that point. So are we good now? So clinically, if your patient's CO2 is high, you're going to see people change the rate. That's why I said this is the only thing you'll see different. Although volume has a bigger effect. Okay? Are we good? There it is, right there for you, all in one space. All right. So, do you want to take your break now and then just do the last hour events, or do you want to? Okay, so come back at 5 till.